Okay. Well, welcome everyone, and thank you for joining us for the first event of CanREACT, the Canadian Research Ethics and Accreditation Talk. So some housekeeping items for today. So for every question, please put them in the Q&A, and you can also submit anonymously. Please upvote any questions that are pertinent and that you want presented first. We'll make sure we sort through those at the very end. And we're also recording this session and we'll be making it publicly available once it's over in the next couple of weeks. So my name is Marie Tremblay, and I'll be your host and moderators for today's session. CanREACT emerged from our work from the Technical Committee for Human Research Standards Development, and also in response to how harmonization initiatives are currently being framed and discussed in Canada. Through our own internal discussions, we kept coming back to the same realization that some of the most important insights in research ethics do not come from formal presentation or policy documents. They come from the very difficult conversations where experienced individuals coming from different roles and perspectives are willing to question their own assumptions, challenge those interpretations, and critically examine where our systems fall short. Too often, the national conversation on research ethics is all about fast-tracking approvals while forgetting who we do research for. It's not for the industry, it's not for principal investigators, it's for us and our communities and our families. When something goes wrong, when harm is significant enough to be visible, the only time we ever know is when it's reported publicly, perhaps as a CBC article, or it makes it as a documentary. If we are really serious about participant protection, then the conversation needs to shift. It needs to focus not only on individual cases, but on the conditions and root causes that make these cases possible. The intent of this platform is to contribute to that shift. CanREACT is designed to have these conversations and to open them up to a broader audience, including those that directly and indirectly involved in human research, as well as those with a general interest in how research involving humans is governed. Our goal is to create that safe space for thoughtful and very candid discussions about how research ethics and oversights are applied in real-world settings. Not just what frameworks say, but how they are interpreted on the front lines, where they function well, and where they create tension. Looking at today's topic, many of you joining us are part of Canada's research ecosystem, whether as research administrators, you're involved in the ethical review of research, researchers, or policymakers. So I'll start with a question that likely resonates across these roles. Why is it in Canada still so difficult for research ethics boards to work together? Why do efforts to harmonize review processes take years to advance, often facing resistance along the way? We all share a common goal to reduce duplication and to improve efficiency, and to also support high-quality research in Canada. And yet, trust remains a challenge. What is it that's missing? Today's discussion begins to explore that question, and we hope that we challenge or support your current perspective and assumption on how we can facilitate functional multi-jurisdictional REB review while also protecting research participants through quality systems. I'm joined by an exceptional group of colleagues, as well as our special guest, Jeremy Levine, who's the Senior Officer for Smart IRB at Harvard University. Jeremy, thank you for being here and for bringing that international perspective to this discussion. Today, we also have Clarissa Fleck, who is the Director of Accreditation for Human Research Accreditation Canada, Martin Latendre, who is the President of Ethica CRO and Veritas IRB, and also a lawyer and ethicist. Erica Monteferrante, who is an ethics and compliance consultant at Filia Group. And finally, Janice Parente, entrepreneur, author, and advocate for human protection. So Janice, we'll start with you. You've spent your career focused on human research protection. Through your recent writing and public engagement, you've raised important concerns about the current state of research governance in Canada. In your book, Ethics on Trial, Protecting Humans in Canada's Broken Research System, You describe a system that, in some cases, is not functioning as intended. For those joining us today, our audience, can you help set the stage? And what do you mean by a broken system?
Well, thank you very much, Marie, for your introduction. So before we can address the broken system, let's talk about the system as a whole, the governance system. When we talk about governance, we're talking about the structures and processes that guide how organizations make decisions and exercise their authority. In human research, governance is what determines whether participants are truly protected or whether we simply assume that they are. Experts often distinguish between good governance and ethical governance. Good governance focuses on transparency, accountability, and effective decision-making. Ethical governance ensures that those decisions are guided by integrity, fairness, and respect for human rights. In human research, they're both essential. In Canada, currently, human research governance is largely reactive. It primarily acts after something has gone wrong, after the harm, after the breach, after the damage is done. And when that happens, the Research Ethics Board is often to blame because it's the most visible part of the system. And some think that it is the system, but that focus misses the deeper issue. Research ethics boards are essential, but their mandate is narrow. Excuse me. They review protocols before research begins. They have limited capacity to monitor ongoing research. They rarely interact directly, if ever, with research participants, and their quality and independence can vary across institutions in our country. They were never designed to carry the full weight of research participant protection alone. That protection depends on the broader institutional system that supports and oversees research, like how researchers are trained and how quality is monitored. These are system responsibilities, not committee functions. This kind of structured system-level governance is often described as a Human Research Protection Program, or HRPP, a proactive system, a system designed to prevent harms before they occur. Good and ethical governance is the why and who of research participant protection, and the HRPP represents the how, the practical framework. And HRPP brings together the core elements of governance, including ethics review, qualification and training, conflict of interest management, privacy and data protections, contracts and legal oversight, safety monitoring, quality improvement, resource management, and clear institutional accountability. Within an HRPP, these functions are not isolated. They operate as a coordinated system designed to ensure that research participant protection is embedded across the entire institution to support ethical research before, during, and after a study takes place. For example, when a study is reviewed, the REB assesses whether it's ethically acceptable to conduct it in humans. But the REB does not control many of the institutional conditions that determine whether research is conducted safely and ethically. Those responsibilities sit within the institution. So even if a study is well reviewed, its ethical conduct depends on systems the REB does not see and cannot influence. We would never accept this in any other safety critical field. For example, in aviation, safety is not achieved by the cockpit crew alone. It depends on a complete system: training, certification, maintenance, incident reporting, and organizational accountability. Safety is built into the system, not left to a single point of review. Yet, in human research, we continue to rely heavily on a single committee to carry out that responsibility. Canada already understands how to build effective governance systems. In animal research, The Canadian Council on Animal Care has, for decades, established national standards and ensured that they're applied across institutions. Animal researchers are monitored, institutions are assessed, standards are enforced. The entire system, not a committee, is accountable for animal welfare. What we've not done is applied that same systems-based approach to human research. This creates a structural vulnerability. When something goes wrong, we look back at that REB decision. But the conditions that allowed the harm to occur often exist outside that decision. We're evaluating the ethics of a protocol without evaluating the systems that deliver it. If we want fewer harms and stronger protection, the answer is not to ask more of the research ethics boards. It's to ensure that the systems around them are in place, consistently applied, and accountable. To summarize, governance is what defines responsibility, and the HRPP is how that responsibility is operationalized. The question may be, how do we ensure that an HRPP is actually in place and functioning as intended? I'll turn to my colleague, Clarissa Fleck, to help us understand how that is done.
Thank you so much, Janice. Yes, that is actually the question accreditation is designed to answer. So accreditation of HRPPs operationalizes the governance model you just described. So it turns this ethical commitment into measurable practice. Accreditation provides this independent verification that a system, in this case, the Human Research Protection Program or an HRPP, is in place, but is also functioning as intended. The idea of independent verification is not new for Canada. In basically every other area where Canadians face risk, we rely on verification. Verification assures us that good governance systems and protection exists within standards-based systems. So it provides us oversight, consistency, and importantly, accountability. In all these systems, protection then is not left to trust or self-reporting. So a few examples are healthcare institutions such as hospitals, which are accredited by Accreditation Canada. We have laboratories that are inspected and operate under accredited quality standards. And to me, the most interesting example is animal research, which is independently overseen through accreditation. And this system has been in place in Canada by the Canadian Council on Animal Care, or CCAC, for over 5 decades. But when it comes to human research, this verification is not consistently applied, even though we have a system of accreditation, which is pan-Canadian and bilingual, offered by Human Research Accreditation Canada, or HRA Canada. Importantly, accreditation for all these systems on the slide is bilingual. It's not mandatory. And accreditation bodies operate independently, not only from bodies such as industry and pharma, but also meaning that they are not government run. Instead, the government can adopt or rely on and respect these systems to ensure quality and protect the public. So for example, in order to receive CIHR and NSERC funding for animal research, organizations must be accredited by the CCAC. This is a condition for funding for animal research since 1984. They could do the same for HRPP accreditation. And then similarly, Health Canada, for example, could require that research be conducted within an accredited HRPP at the time of clinical trial application. So I'm mentioning that HRPP accreditation is not consistently applied. So where is Canada heading then? The governance gap that Janice referred to is relevant and current as Canada is moving to modernize clinical trials. It became clear that the goal is to make Canadian research more efficient by reducing red tape. And within the modernization of clinical trials being proposed, there is an effort to streamline REB review processes. Of course, streamline can be beneficial, but only when paired with strong governance. One model includes REB qualification as an entry point. It then designates one REB as the REB of record to approve research across multiple institutions. But Qualifying the REB does not independently verify this institutional system within which the REB operates, right? Qualification of REBs cannot promote participant protection because an REB, even if qualified, cannot protect participants alone. Focusing on streamlining the REB processes without strengthening governance it's like renovating the kitchen while the foundation of the house is cracking and the roof is leaking, right? Visible improvements can then mask these deeper structural risks, and those include legal reasons as to why this model may not be sustainable, but I will leave that discussion to Martin. Another important point here is the impact on Canadian research with respect to other countries. Canada is already behind other countries implementing these multi-jurisdictional review structures. And what we've been doing for the past 2 decades is making Canada different and less able to compete. And now we are contemplating a multi-jurisdictional review, REB review model that would not be compatible with what other countries are doing. So this is a barrier to international collaboration and interoperability. For example, REB qualification does not align with the governance frameworks used in international reliance models. And these, as Jeremy will present soon, employ HRPP accreditation, not REB qualification. So where do we go from here? Since 2020, Canada has national standards for human research and HRPP accreditation, an HRPP accreditation program that is rooted in those standards. It's ran by HRA Canada. The success of Canadian HRPP accreditation program is evidence in the increasing number of organizations pursuing or showing interest in the accreditation process. We are now seeing federal departments require, some federal departments require HRPP accreditation from their contractors. So for example, the Privy Council Office, the National Research Council, and the Department of National Defense. And they do that because verification through accreditation assures they can rely on the research their contractors conduct or review. These efforts can achieve participant protection while streamlining research. So by having this functional HRPP and attaining accreditation, organizations can trust each other's reviews, and this creates a system of reliance. In other words, we're aiming at participant protection, but we're also building a system for harmonization. And this harmonization occurs not just with the REB review, but in other aspects of the research, like the conduct of the research. And this is the underlying mechanism to ensure a single REB review model can work. And in fact, is the mechanism used by Smart IRB in the United States and other models internationally. And I think this will be a good moment to pass the mic to Jeremy, who will talk about how this works in the US.
Perfect. Well, thank you, Clarissa, and thank you, CanREACT, for the opportunity to speak with you all today. As Clarissa said, Smart IRB, it's a comprehensive solution designed to provide efficiency, transparency, and quality to multi-jurisdictional research ethics board review. The first question we always receive is Smart IRB an IRB? It is not. It is an acronym for Streamlining Multi-Site Accelerated Resources Trials, IRB. If that seems like a lot, you can just call it SMART. But Smart IRB developed in a similar way that Canada is undergoing this modernization effort. Smart IRB also derived out of a long national conversation on how to modernize the research ecosystem for what now is a burgeoning force of what we call single IRB. The effort started in 2014, when the United States NIH funded a collaborative effort to develop and sustain a common reliance agreement, standard operating procedures, and resources necessary to make this transformation possible. One of the most important things with this was bringing together national leaders, experts, focus groups, public comments and feedback with thousands of questions, thousands of comments on how to forge a consensus model. And we spent about 2 years doing this in order to reach all of the thorny issues and grapple with all of those topics and to derive at Smart IRB version 1.0, which launched in 2016. And over the course of the last decade, we've had 2 subsequent versions, including last year with the arrival of version 3.0 of the Smart IRB agreement. Now, it's all volunteer, it's all free to use, but it has grown to be the most prominent reliance agreement in the United States. And indeed, in the world, with over 1,450 smart IRB participating institutions. So what's the secret sauce? How do you get 1,450 institutions to agree to just about anything? Well, before we go into the actual model, I want to touch back on a point that Janice made about these reactive approaches, because this is actually one of the problems in the United States that Smart IRB was there to solve. On the left-hand side of the screen here, you see a number of the issues that are prominent in these reactive approaches. First and foremost, limiting to the IRB or REB alone, putting blinders on all of the other aspects associated with the institutional responsibilities. They often emphasize the seeding of the review only, so they're not looking at how are amendments handled, how is continuing review handled, how are problems and reportable new events happening. And they're silent on those roles and responsibilities throughout the life of a study, which creates all of these efficiency gaps because something happens, who knows how to handle it, right? There's nothing written, there's nothing to follow. We also had a lot of these what we call one-off agreements or IAAs, which have high administrative burden and non-scalable impact. As well as, there's really no resources to handle these processes, which means that we cannot harmonize and we can't move the needle. So these were all of the kind of problems, some of which still exist for those who are outside of SMART, but these are the kinds of problems that SMART was looking to solve when it formed. And indeed, the SMART approach is different. We don't look at only the IRB or the REB. We embed the HRPP into the agreement itself. So if you look at all of those items, the Smart IRB agreement actually has sections for each of these items that outline the responsibilities for each whether it's a relying institution or whether it's a reviewing IRB, the roles of these institutions both within and between the institutions. The difference is that by providing clear roles and responsibilities for study teams and HRP peers throughout the life of a study, you can ensure that the institutional obligations are met. Now, I know what you may be saying. You say, okay, well, we have an REB, and I don't know, maybe this doesn't work for my institution because we don't consider it an HRPP. From the Smart IRB perspective, we really care. It's less about what you call yourself in terms of an REB or an HRPP, and it's more about what you do. It's more that you're going to handle these items under the terms of the agreement. So that might mean that there's a conflict of interest at your institution. That means the relying institution's responsible not only for managing that conflict, but sending that to the reviewing IRB for their discernment as well. Now, if you don't have any of these aspects in your institution, other agreements may say, well, I'm sorry, you can't participate in this clinical trial, right? Smart IRB, in addition to being comprehensive, is also very nimble. So we have default and flexible options available to ensure that institutions of all types and sizes are able to participate in the process. You may have seen that compliance monitoring, for example, clicked there. And I've personally had this experience myself, where they'll say, we have everything here. We can do all of this as a relying institution, but our compliance monitoring function is really, pretty slammed right now. We don't have capacity to handle this in a research capacity. Well, that actually can be okay with mutual agreement between the institutions to have that capacity covered, for example, by the reviewing IRB or a third party. The point is to have this information documented and agreed upon by institutions to make sure that nothing falls through the net, right? We don't want to lower these barriers or lower these standards, rather. Now, in order to do this, a little comprehensive approach, we recognize that you need to have resources that make this possible and make excellence easily obtainable. So I'm going to give a good example here. We have a robust resources library. One of my favorite documents when I ran a academic medical center reliance program was this overall principal investigator checklist. It was something that was given to every researcher to say, these are your responsibilities and your obligations when you are serving in this capacity. And if it's given throughout for your entire program, you end up in a situation where everything is covered from a compliance angle. Very important. And these materials are also customizable by your institutions. So it really gives a leg up if you're trying to make sure that you can work efficiently and compliantly and transparently. In addition, we talked about harmonization, and this is a major initiative of Smart IRB. We have about a dozen harmonization white papers across a wide spectrum of topics here. I have the single IRB continuing review process listed here, but I encourage you to take a look at our harmonization papers. We actually have a few coming out very soon in local context. So these are very important to moving the needle, to making sure that institutions can work closer together, operate more similarly. And this is important, again, from quality, transparency, and efficiency. So let's go into this a little bit. How do you get into the Smart IRB? How do you get 1,450 institutions to sign on to the same thing? A lot of people think that it must be something, back of a napkin. We actually have higher eligibility standards than the bare minimum of federal regulations. So I mentioned that it's free to join for those who meet the following criteria. Now there are two, possibly three, if you have an REB to join Smart IRB. You must have an active federal assurance from a U.S. governmental department or agency. The most likely one that you might be aware of is the federal-wide assurance from the Department of Health and Human Services. This is easy to obtain, takes about 20 minutes to apply. There's some demographic information about your institution, as well as attestations to all of the ethical principles we know and love, Belmont, Helsinki, etc. We have to have someone at the wheel, a designated institutional point of contact. This is a person that will be listed on the participating institutions page. It's publicly available. It's a way that we ensure that if there's a problem, someone is there to answer the call. And third, and most important to this conversation, is that if you have an IRB or an REB, you must complete or initiate an HRPP quality assessment within the last 5 years of joining. So, how do you do that? Accreditation. Think of HRA Canada, think of AHARP. You could have an audit or a verification. If there's a federal health authority that is auditing your HRPP, that would be one way. You could do a third-party verification of the HRPP quality. This is done, the big consulting firms often do this. And we also offer the internal quality assessment from the Office of Human Research Protection's Quality Assessment. You must pass all three of these if you have an REB in order to join the Smart IRB. We have these because we believe that the comprehensive nature of the Smart IRB requires institutions to do a little more than the bare minimum. That being said, most of our institutions, once they join, they operationalize this model for their entire portfolio. If they find it's really easy after you do 1 or 2 studies to really get in the swing of things. Now, Clarissa had mentioned about the international standards, and I want to talk about this just briefly. Because indeed, HRPP accreditation is the rule rather than the exception in the United States. Let's go through a little bit of the data here. So 85% of the top US NIH-funded academic medical centers have completed or initiated accreditation. 70% of US medical colleges have completed or initiated accreditation, and all major US commercial or independent IRBs are accredited. What this means is that the vast majority of particularly biomedical research in the United States is happening under the basis of HRPP accreditation. This is the standard way of doing business. And in fact, since the United States does a majority of clinical research around the world, that means that this is really a dominant mode of doing things. And indeed, this data is also borne fruit from Smart IRB data. About 92% of US AHARP accredited institutions are Smart IRB participating institutions. About 80% of the Reliance System research, that's our online portal, involves an HRPP accredited reviewing IRB. And all major US commercial and independent IRBs are Smart IRB participating institutions. Take these things together, and this means that this is the common way of doing research on a multi-site jurisdiction under one IRB, or REB, as you will. This is the standard way of doing things. Many reasons for this. They are really twin and complementary pillars, but this is really the standard way of doing things in the United States. I'll leave you here today with a few key takeaways. That HRPP perspective is key for effective oversight and research conduct. This is something where, I think there's a blind spot that a lot of people don't really see initially, but you need it ethically, operationally, regulatorily, or if you think of, if those things don't move the needle for you, think about the reputation. If you run into an issue, it's not the IRB or the REB that is called out, it's the institution that gets called out. If there's a newspaper article about it, they're not doing the newspaper article about the REB. It's the institution that is going to be discussed here. So think about that. That HRPP angle, not only does it protect the participants, it also protects your institution. So it's a win-win. If you can't protect participants, if you can't protect your own institution. So these are something to think about. Smart IRB makes that approach and that transition to HRPP excellence not only easy, but free. It's the right price point and it's all available. It's customizable. We adapt institutions frequently from this old model to this, consistent, harmonized, integrated approach. And finally, we'd really urge you to join. Canadian institutions should join the Smart IRB network today and, engage in research with the hundreds of thousands of researchers around the world that are already part of this system. We are growing rapidly, and, it's something where, the future is global. And so this is really where the future is. It's to have free, integrated resources, to have a community. You can use all of our events all of our information is free and available. And if you have any questions at help@smartirb.org, we're happy to have a conversation, provide expert consultation, and really just lead the way. So I'm going to hand it over to Martin, who will talk about the legal aspect of things. Martin?
Thank you very much, Jeremy. So today I want to focus on one narrow legal issue in the discussion around multi-jurisdictional ethics review and the proposal by Health Canada and CanREACT to adopt a national single REB model. So the question is, what are the legal consequences when sponsors, investigators, and institutions delegate ethics review and oversight under a multi-jurisdictional REB model? We will see that the answer to this question is the same across both normative frameworks that govern clinical research in Canada today. ICH-GCP E6R3, now in force, and the Tri-Council policy statement. For illustrative purposes, we will use the currently proposed national single REB model by CanREACT as an example, as no other national REB models have been proposed to date, and the concept of a national REB is not defined in Health Canada's proposed clinical trial regulatory modernization. However, this analysis is a cautionary tale for any future multi-jurisdictional REB models. So viewed in practical terms, CanREACT's national single REB model is not a research ethics board as defined under ICH-GCP. As stated in its own materials, it operates as an integrated operational framework. The model includes a centralized submission platform, standardized application and consent templates, an internal REB qualification process, a centralized mechanism for selecting the REB of record, and strict submission and review timelines for both the selected REB and institutions. When assessed through that functional lens, the regulatory characterization of what is proposed fits the definition of a service provider, both recognized under ICH-GCP and the Health Canada proposed draft clinical trial regulations. ICH-GCP defines a service provider as an organization that delivers services used by sponsors or investigators to carry out trial-related activities. Under that definition, CanREACT is providing a service relied upon by sponsors, investigators, and institutions to conduct ethics review and ongoing oversight. Once framed in those terms, another question follows. What does GCP say about responsibility when trial-related activities are delegated to a service provider? ICH-GCP speaks to this issue directly. Delegation changes who performs certain trial-related activities, but it does not change who remains accountable for them. Sponsors may transfer activities to service providers, but they retain ultimate responsibility for protecting participant rights, safety, and well-being, as well as for the reliability of the trial data. Additionally, sponsors must actively assess whether a service provider is suitable to perform the activities being transferred and must maintain appropriate oversight, including where activities are further subcontracted. In other words, delegation does not relieve the sponsor of its governance responsibilities. It actually makes them more critical. And the same logic applies to investigators. Investigators may delegate trial-related activities and may be supported by sponsors in identifying service providers. But the final judgment about whether a provider is appropriate rests with the investigator. Investigators retain ultimate responsibility and must exercise oversight that is proportionate to the risk and to the importance of the activities being delegated. Taken together, ICHGCP establishes a consistent principle. Authority can be delegated, but responsibility is retained. And that principle aligns directly with the logic of the Tri-Council policy statement. Article 8.1 of the Tri-Council policy statement allows institutions to use alternative ethics review models for multi-jurisdictional research, but only on one condition. Institutions remain responsible for the ethical acceptability and conduct of research under their auspices. That regulatory position is clear and consistent with ICHGCP. The TCPS, however, raises a deeper concern regarding the governance structure of CanReview's proposed model. As currently designed, CanReview operates as a centralized ethics review coordination platform while also qualifying and designating the REBs that act as REBs of record for multi-site studies and imposing strict review and submission timelines on both research teams and participating REBs. From a governance and TCPS perspective, that creates a structural conflict. A system that both delivers the services and qualifies the providers required to sustain it is inherently self-validating. The platform has an inherent interest in qualifying enough REBs to maintain continuity of service and meet timelines. Yet, under both ICHGCP and TCPS, institutions cannot outsource responsibility for ensuring the REB of record is fit for purpose and independent. They may delegate the assessment process, but not the responsibility itself. When qualification is embedded within the service, institutions are left relying on self-qualification, which undermines independent oversight under ICHGCP and weakens compliance with TCPS. That structural issue brings us directly to the conclusion of this legal analysis. So takeaway number one, under ICHGCP, CanReview's model operates as a delegated service. It requires that delegation be accompanied by appropriate oversight and retained accountability on the part of the sponsor and investigator. The TCPS is explicit. Institutions remain responsible for the ethical acceptability and conduct of research under their auspices, regardless of where ethics review is conducted. Takeaway number two, why structure matters. As currently structured, delegation of ethics review to CanReview cannot be considered compliant with Canadian normative frameworks. The governance architecture conflates service provision, qualification, and oversight into a single structure, creating a self-qualification model that defeats the retained responsibility requirements of both ICHGCP and the TCPS. And this is where, this might take away number three, at least providing a path forward, and this is where Human Research Protection Program accreditation really comes into play. As Janice and Clarissa mentioned earlier, HRPP accreditation provides practical, program-level assurance that institutions are genuinely exercising, managing, and monitoring their research activities in compliance with applicable ethical and regulatory obligations. HRPP level accreditation combined with institution-governed reliance agreement and proven multi-jurisdictional ethics review models such as SMART IRB provides a defensible path forward. These mechanisms allow institutions to collaborate efficiently while preserving accountability, protecting research participants, and remaining fully compliant with both ICHGCP and the TCPS. And with that in mind, I'll turn now to Erica Monteferrante, who will help us synthesize the panel's interventions through a research ethics perspective.
Thanks, Martin. Before I get started, I want to share a perspective. I just spent last week with the CCAC doing a site assessment for an animal research program at a major Canadian university. This involved visits to 20 animal facilities, including the one that houses the cows in this photo, meetings with countless stakeholders, and the review of hundreds of documents and procedures, but for human research, the same level of institutional governance is missing. I'll now briefly build on what we've just heard about governance, accreditation, and reliance, and focus on what this means from an ethical perspective. So we've heard that participant protection depends on system-level governance. Accreditation provides independent verification that those systems are in place and functioning. Models like Smart IRB operationalize reliance through clearly defined roles and responsibilities, and importantly, that delegation does not transfer responsibility. So with all of that in mind, we can consider the ethical risks when these elements are not aligned. I'll highlight 5. The first point is the illusion of protection. So ethics approval creates confidence, but it can also create false confidence. Approval does not ensure that the systems required for participant protection are in place and functioning. So this shifts us from demonstrable protection to assumed protection. The second point is the diffusion of responsibility. In multi-jurisdictional research, one REB reviews while multiple institutions remain responsible. And as we've just heard from Martin, delegation, again, does not transfer accountability. But in practice, this creates a structural problem. Multiple institutions rely on a single decision with no single point of accountable oversight. And without clearly defined and verified systems, responsibility may not be clearly operationalized in practice. And when responsibility cannot be operationalized, accountability breaks down. And in failure, responsibility becomes difficult to trace and sometimes effectively untraceable. The third point is inequity in participant protection. When institutional systems are not consistently in place, participant protection can vary by site. So, 2 participants in the same study may experience very different levels of oversight and support, which raises a fundamental ethical question. Can research be considered ethical if protection depends on location? The fourth point is the misalignment between efficiency and accountability. There is strong pressure to streamline research, but efficiency without governance introduces risk. When a study is reviewed, the REB assesses whether it's ethically acceptable, but the REB does not control many of the institutional conditions that determine whether research is conducted safely. Those responsibilities sit with the institution. So, even if a study is well reviewed, its ethical conduct depends on systems, like Janice said, that the REB does not see and cannot influence. And in a centralized model like CanREViews, this creates an additional risk. A single flawed REB decision can be propagated across multiple sites. So risk doesn't just exist, it scales. If we follow this logic just one step further, a fifth issue starts to emerge, one that settles in over time but is harder to reverse. That's a slippery slope towards forum shopping. So when efficiency becomes a priority, ethics review could start to behave like a variable. Sponsors and institutions may gravitate, intentionally or not, towards REBs that are perceived as faster or less burdensome. The role of ethics review then begins to shift from independent scrutiny to a mere step in the workflow, and that is where ethical erosion begins. So, what does this mean? Ethical review cannot be separated from the systems that support it. Reviewing a protocol is not enough. qualifying a committee is not enough. Participant protection depends on whether institutional systems are in place, independently verified, and functioning in practice. And critically, if something goes wrong, saying we relied on can review is not sufficient. Institutions must be able to demonstrate oversight, system control, and functioning protections. If they cannot, accountability becomes difficult to establish and responsibility becomes harder to defend. Multi-jurisdictional research is ultimately a test of whether governance, verification, reliance, and responsibility are aligned. Institutions remain responsible for participant protection regardless of where ethics review occurs. Again, a functional system requires institutional systems that support participant protection, independent verification that those systems are in place and functioning, and clearly defined operationalized responsibility across all sites. The National Singular REB model for multi-jurisdictional research proposed by CanREACT does not establish these conditions. It separates ethics review from the systems that support it. It relies on REB qualification rather than verification, and it leaves institutions responsible without ensuring that they can fulfill that responsibility in practice. So it cannot function as a reliable framework for participant protection. Earlier, we heard Jeremy explain that a functional model already exists. Models like SMART IRB demonstrate that multi-jurisdictional review can work when it's built on verified systems, structural reliance, and shared accountability. And HRPP accreditation provides the mechanism to verify those systems and enable that reliance. Bottom line, participant protection cannot be assumed, and the single biggest risk is the inability to demonstrate in a verifiable and system-level way that participant protection is actually being achieved. Functional multi-jurisdictional REB review requires independently verified institutional systems and clearly operationalized responsibility across all sites. Thank you.
Thank you so much, Erica. And this concludes all of our talk from our panelists. We have a couple questions in the Q&A that we'll go through. And if you have any additional questions while we're answering, please feel free to have this discussion with all of us. So we're going to start with this first one, which is submitted in two parts. So I'll read it. There is, I believe, a clear need for a more efficient REB system in Canada, since our current system of needing individual approval at each institution is hugely inefficient compared to the UK. But clearly lots of challenges. So the first question, and I think that will go to either Janice or Clarissa, do you think that accreditation would be sufficient to permit an institution to use an external or central REB?
Having had run an accredited REB for the last 30 years, Veritas, yes, as soon as we got accredited, we were able to work with other accredited research ethics boards anywhere in the world because we were accredited according to the highest standards available by a third party. So that brings in the harmonization immediately. What SMART IRB has done is said, we're going to make it a little bit easier for you to do that. We're going to create a reliance model structure. The model that's being presented through CanREACT is not that model. It's going to be different than what we're all using outside qualification. And it also, as we've tried to present today, it also takes away the actual governance structure of the institution and places it on the onus of research participant protection only on the REB, which is the problem we've had in our country.
Thank you. Anything to add, Clarissa?
No, those would be all my points.
So part number two, I think we'll get Martin to answer that. How can the different legislative requirements between provinces be overcome to move a coordination of REB review forward?
Well, essentially, through either the smart IRB model, the reliance model, it is governed by the institutions. So the institutions keep control over the conduct at their institutions. And therefore, there are specific requirements at a provincial level. These will be taken into consideration at the local level. That doesn't mean that you cannot collaborate and have a centralized ethics review of the study and looking at all the central level issues. But at least you have control over your local elements that you want to integrate into the management of the project at within your institution.
And I'll add another level to that. That also helps with community-based authorities and oversight as well, right?
Correct.
So another question. So agree with so much of what has been presented, but why has uptake of accreditation in Canada been minimal? I may be wrong, but I don't think any of the major academic institutions have done this. Is this because of a lack of compulsion? Does it relate to the fundamental challenges why we have no national coordination of how REBs, etc., should work at a federal governmental level? Who would like to take this question? Janice, you go ahead.
I live and sleep this. So it's in my book I wrote about Maslow's hammer, that if the only tool you have is a hammer, then everything looks like a nail. And that's been the problem with us for decades. We think of research participant protection as the research ethics board. And once we change that paradigm, then we can see the system. And that's what needs to that's where we need to focus, not on the REB, but on the system that supports the REB. There's a lot of other things going on, as we've discussed. And I think that it's just been a narrow vision of what research participant protection is.
So to supplement that, there's another question that relates to this. Could you clarify if accreditation would create a uniform interpretation of our national policy, the TCPS? Often in multi-site studies, owing to the wide variation in REB review protocols, are becoming fractured and the study implemented inconsistently. For example, waivers of consents are not applied uniformly across the country.
You want me to handle that one too?
Yes.
I feel like I'm talking so much. So the National Standard of Canada for Research Ethics Boards, which was published in 2021, and then just we had an edit. The first edit was this year. It is rooted in the Tri-Council policy statement. And what a standard does is it takes the policy and ICHGCP and other normative texts from around the world, and it tells the person using the standard what is required in order to meet it. So there's nothing new in the standard that you didn't already see in the Tri-Council policy statement or in ICHGCP. And as those documents get updated, renewed, so do the standards upon which the accreditation program is based.
Excellent answer. This one was sent anonymously. So what do you think are the main barriers or challenges that may be contributing to hesitancy among Canadian institutions to adopt formal HRPP structures and pursue accreditation? And perhaps I would be the best one to answer this because I do work for Nova Scotia Health and building an HRPP. A lot of the challenges, I think, comes from pioneering and adapting those standards within your current structure. There's always a limited resources. There's always creating new processes that weren't there before. That takes a lot of creative energy to put into place as well. And then some of it is just funding. So you need people to be able to create and develop an HRPP that reflects your internal structures. And that requires time. Maybe not necessarily new individuals, but it does require time. And that's why there's consulting companies in the US and Australia as well to help institutions build those structures. And so this is perhaps a call to CIHR and some of our major federal funders. Creating a program to help fund institutions will help accelerate those HRPP structures and really help Canadians to adopt HRPPs.
I'll just add to what you said, Marie. I think we talk a lot about the cost of pursuing accreditation, but I think a few of us alluded today in the presentation of the cost of not obtaining accreditation. And, you know, Jeremy alluded to this, Martin alluded to this. It's this idea of, you know, the front of the newspaper and the CBC article on the tragedy that could have been prevented if you had accreditation. So I think that is, it's a paradigm shift towards participant protection, and the efficiencies and the harmonization, they just are a consequence of that decision.
And then we have one question here on the political state of the US. So Jeremy, this will be directed to you. So in regards to the political climate in the current state, especially when money and funding was taken away from Canadian institutions by the current US administration. So in everything involved in US research and is being run by anti-science, anti-choice, and anti-vaxxers. The US also refuses to engage in any research done with diverse researchers and subjects. So how does that make Smart IRB model compatible with the Canadian model?
Oh, absolutely. And I really appreciate the question. So with the first and foremost, what I'd say is that Smart IRB, it doesn't belong to any, government agency or anything like that. It is a treaty that belongs to her participating institution, her members, right? So we represent the community. So I'll start with that and also say that, Smart IRB does not distribute or determine who is going to be the reviewing IRB. It doesn't obligate your institution to participate in any research. We always want our member institutions to take a look and make sure that when they consider participating in a research protocol, that it aligns with their institution. So Smart IRB, what it really does, it allows your institution, it empowers it to work as frequently or as infrequently with other fellow member institutions. The other aspect I would say there is that there is a significant amount of investigator-initiated research or sponsor-initiated research, which does not necessarily follow under the political purview, right? So whether you participate or not, and whether you make those choices, you always are going to want to evaluate whether something is aligned with your values. I think this is always going to be true, and Smart IRB allows you to do that. It doesn't assign an REB and say that you have to participate and that you have to do X, Y, Z. So empowering the institution to make those choices is part and parcel with what you are saying, right? So you've established the values, and we really like that, actually. So with Smart IRB, you can join it, and then if you run into those types of situations, there is no basis by which you are required to join a protocol of that kind. So that is all up to you.
If I can add something to Jeremy's intervention, I think that the goal of inviting Jeremy to this talk is to show alternative mechanism for multi-jurisdictional research that are functioning, that have been well established, and that are grounded within a regulatory framework that takes into consideration compliance and governance. And I think that this was the purpose of inviting Jeremy. Yes, we should not be reinventing the wheel. I find that sometimes Canada, we have a way of wanting so much a Canadian-made solution, and I think sometimes it's creating additional barrier rather than creating efficiencies. But that's my take on it.
Thank you, Martin. So this next question, on the website, CanReview includes HRE Canada accreditation as a validated pathway to become a participating REB within that model. So can accredited REBs join CanReview? Janice.
So CanREACT did not reach out to HR Canada to put us on their website. That's their website. What strikes me about that is it's also put as an equivalent accreditation model as CTO's qualification of REBs and chair's qualification of REBs. Those are apples and oranges. We're delighted that they can see that accreditation is a path forward for reliance, but it can't be the same as a qualifying one part of an HRPP.
Thanks, Janice. This one relates to communities, and I really like this question. So perhaps maybe Jeremy, you can answer that one. It would be interesting to know how Indigenous people and their voices can be increased in this area with Smart IRB. Can you comment on how that happens in the US?
Absolutely. There are two aspects I would say here. In the United States, with Smart IRB, we emphasize local context or what we call local considerations, right? So that's the items on the ground, the cultural heritage. Maybe it might be language, it might be with laws, and this comprehensive view of who are those on the ground that are experiencing research. So first and foremost, we center local considerations, which would cover including like Indigenous populations, giving them an opportunity to tell, for example, if they're in the relying institution role, what is needed in order to adequately cover a given population. So we start with that first and foremost throughout the entire life of a study, providing said populations that opportunity. And secondly, sorry, I lost my point. The major idea of for Indigenous folks, for example, who do not have an IRB, Reliance and Smart IRB allows a pathway for participation. In previous models, if we think about before Smart IRB, a lot of times Indigenous groups were, it was a university professor that came to the Indigenous group, and the Indigenous group wasn't allowed to be what we call engaged in the research. They were subjects to the research, but they were not part of it, right? And this is fundamentally a problem because, every group should be able to be a participant and be able to engage not just as a participant, but as a researcher. So one of the things that Smart IRB has done, one of our emphasis in the last few years, has to bring in like what we call non-traditional research sites, or those who maybe in the previous models were underrepresented in research, and to give them a pathway in as well. And so this is one of the things where if you have this holistic approach, you can cover both those local considerations, including those special circumstances for example, for Indigenous or the marginalized or underrepresented, but also ensure that they can not only participate as subjects or human participants, but they can also be researchers as well. They don't need to establish their own IRB or REB to participate. So there is a democratization angle, and there is also an aspect where we are ensuring that the Indigenous can participate and have their voices heard.
Thanks, Jeremy. This other one, I guess it's to the entire group because we've been advocating this for a long time. Is there an opportunity, do you think, to push for CIHR or Health Canada to mandate accreditation? What would it take for that to happen? I don't know who wants to take this on. Yeah, Janice, like you've been there.
I'll just say that I did meet with the Minister of Health, Marjorie Michel, in a lengthy conversation we had together last month. And we walked through how it could be incorporated into CIHR's funding policy and in the CTA forms, the QIU and the REBA form. So we're not finished yet. We have many more meetings to go, but that's the ultimate goal of HRE Canada.
I'll just add to that. I mentioned this during my talk, but I think the format that we probably would see happening is what was done with animal research as a condition of funding. That is a likely scenario as an outcome for government, I would call it reliance on HRPP accreditation, or from Health Canada that there is HRPP accreditation in place at the time of the clinical trial application. So those are ways that, like I mentioned in my talk, that the government could respect, rely on, or promote this type of system, such as it has done with the animal system. And I guess, potentially healthcare as well. So that would be sort of the format that would come out potentially, but we'll see.
If I can add something to this, again, I will fall into the sphere of the opinion. In the United States, there were no federal mandate to be accredited. It's the leadership of the institutions that saw what happens in Johns Hopkins with the death of Ellen Roche, and they gathered together and they committed to never again should this happen. And I don't know what it would take in Canada for the leadership of the institutions to go and seek accreditation for issues like the PASS study that happened not long ago, happened again where indigenous teenagers got severely harmed in a study that should have never been approved. So if we're waiting for the government to do something, there's something institutions can do tomorrow. And it's really to take the leadership and seek accreditation if they really care about their research participants.
I'll just add that many are. We are accrediting institutions and health authorities in the country. We just don't talk about it until they're finished their accreditation. So,
thank you. Next question for the group. What is the role of the FDA in championing smart IRB? Again, if there is a standing practice, why not adopt or at least use for context and direction?
Great question. So we are awaiting guidance from the FDA in response to what was called the 21st Century Cures Act, which was set to modernize the research ecosystem. Their FDA's official guidance has not yet come out. However, I'll say even without an FDA mandate, for example, there is data suggesting that a majority of FDA-regulated clinical trials, for example, are operating under not only single IRB, but accredited single IRBs. So this is something that is already moving, even absent a federal mandate from the FDA. But I'd say stay tuned. We are expecting to see something. Actually, we've been expecting since the fall of 2024. But of course, the guidance comes when the guidance comes. But I would expect to see it. Stay tuned, TBD on that modernization in the last piece of the American regulatory scheme as far as is really the FDA. So stay tuned on that.
Thanks, Jeremy. And then the last little bit is more of a comment. So I'll read it out loud. I just wanted to make a comment. So many stakeholders in clinical research, such as sponsors and sites, feel like it is okay for the IRB, whether local or central, to be approved. Great if approval is obtained, but it is everything outside of this approval that matters once you have approval. It's not just a stamp. It's about working ethically, your actions, your words, your decisions after the approval from all of the stakeholders. I'm very surprised that any local or central IRB does not require sites to enter timely data. In early phase study, the data is important safety information. So it comes again where the HRPP is that shared responsibility governance system that we've been talking about. So it's great. Thank you to Dawn for that comment, because it does resonate with this group and what we hope to achieve. And so we've come to the end of the question and the end of this webinar. Thank you to our audience, and we hope to see you again on another edition of CanREACT in the near future as we plan for another section. We will be posting it live on LinkedIn, so please stay tuned and follow us. It is sponsored by HRA Canada, so they will be posting on their website and their LinkedIn as well. So make sure to follow us. Thank you, everybody, and have a great afternoon.